see it.
All right, Assalamu alaikum, everyone. So we're honored to have Dr. Rabia Latif with us, and we also have Ms. Zainab Suara, soon to be Dr. Zainab Suara, with us presenting today. So Dr. Latif will have the floor for the next 30 minutes. Just a bit about Dr. Latif before we get on. Rabia Latif is a neuropsychologist with extensive medical background. She donates 100% of her time to serve those in need free of charge. She also started a charitable and low-cost organization, iAmerica, to provide quality medical, substance abuse, behavioral and mental health services to underprivileged. In 5 years, iAmerica served over 300,000 individuals out of 5 offices focusing on bilingual and low socioeconomic backgrounds. So we welcome Dr. Rabia Latif. She'll be presenting for the next 30 minutes. We will have a Q&A session at the end of this lecture. So Dr. Rabia Latif will be speaking for 30 minutes, followed by Ms. Zainab Suara for another 30 minutes. And we request that for our online audience, any questions that you have, you write them down in the Zoom chat box. And for our in-person audience, we request that any questions you have, you write down on this card paper. And at 4:15 Yale time, so that's in exactly 1 hour from now, we'll get on with the Q&A with our discussant. So without further ado, Dr. Latif, are you ready to begin?
Sure. So my name is Rabia Latif. Thank you so much for being here. Bismillahirrahmanirrahim. Just want to correct the typo. It's 30,000 individual, not 300,000. Inshallah, soon we'll be there. But just want to work on the, correct the typo. All right. So where we are. Okay. So, oh man, I'm having technical difficulties.
No problem.
So the topic here is, so increase of somatization and depression among Arab Americans and Southeast Asian population as we emerge from social isolation. So just want to talk about, thank you so much for having me at the conference. I am honored to be here. At one point, I was a participant here and among the audience, so it's an honor for me to be able to present here. A little bit of background about why we did research, and it was something ongoing, and I'm again very honored to be able to present something which we worked on for the last 2 years. COVID, as we all know, is noticeably responsible for a lot of health and mental health issues, but in particular mental health issues such as anxiety, depression, and panic attacks. The reports and the diagnosis of major mental health diagnosis skyrocketed over the past couple of years. This research aimed to investigate the psychological effects of particularly depression and somatization while we are emerging supposedly from pandemic, but I feel like we're still there. Exploring the mental effects and the impact of pandemic both affected us both at individual and macro level. However, our main focus for today's presented research is to look into the ethnic groups, in particular Arab Americans and Southeast Asian. So just want to talk about why the depression diagnosis is very important. It is the most commonly diagnosed diagnosis worldwide, and it kind of goes beyond just the psychological side effect. It does directly affect the quality of life and daily and physical functioning of our being and existence, in addition to the somatic health, which again, some people name it stress, some people directly link it to depression. And some of the major diagnoses when we're dealing with the somatic symptoms are migraines, chronic pain, cardiovascular related issues, stroke, obesity. They are very common side effects. One of the other things we have been seeing lately over the last 6 months since I guess our societies has opened up, a lot of referrals, like every week we get like 10, 15 referrals from the local hospitals because somebody went into the hospital believing they are having heart attack, but they were actually having panic attack. So it's something just to bring it up. The increase of depressive symptoms could, again, like I said, due to be many factors, but then something I wanted to put in from a medical perspective was, it could be because of metabolic immunoinflammatory issues, automatic or hypothalamic pituitary adrenal axis, degeneration or hyperactivity of our, again, HPA. However, most of the time is metabolic symptoms abnormalities, which are directly linked to our GI issues, whether it can end up flaring up your IBS, which is irritable bowel syndrome, obesity, diabetes, or even stomach ulcers. So, okay, now let's talk about somatization. Why somatization is directly linked with depression. Again, depression itself is pretty much, you want to look at it more like AIDS. AIDS itself usually don't kill people, but it's mostly the side effect. It could be whether it's a fungus growing on your brain or other side effect, but 90% of people at one time, it was estimated, died of pneumonia. Same thing goes with somatization and depression correlation. The major issues comes from the somatic factors or diseases, believe it or not. So that's why we always study the physiological or psychopathological conditions. Especially, it's very prevalent among immigrant ethnic groups. And again, our main focus was Southeast Asian and Arab American. It is estimated that depression alone and combined with other comorbid somatic disease accounts for great number of psychiatric and psychological diagnoses worldwide, in particular in US. And depression, and again, a lot of time when we are diagnosing depression clinically, it's one of the top 3 most diagnoses after AIDS and heart attacks. So overall, our groups, especially ethnic groups, according to the research, they are usually diagnosed more prevalently with depression. Now, let's talk about the third component of our research is the social isolation, which also contributes to a number of factors. We basically break the family bonds and then social bond during isolation, which itself can trigger stress and then leads to a number of psychological effects. So you don't have to shoot somebody if you want to break them. Social isolation can do worse. Overall pandemic, just trying to make a case, pandemic is not new to humankind. Most recently, we had dealt with our our grandfathers dealt with plague, smallpox, malaria outbreak. In Southeast Asia and Middle East was dengue virus. They are still trying to deal with it, flu, when we're supposed to kind of overcome it since 2000, but the rest of the world is still dealing with small epidemics. But then this pandemic is huge because in our generation, we haven't seen something as huge as COVID-19 pandemic. So before the pandemic, our psychological and behavioral response to the pandemic somehow was unknown. We looked at the person most in terms of resilience, distress, reaction, health risk, and then we assessed the psychiatric disorder or psychological disorders. But now, since COVID-19 happened, we're talking about millions of people being affected and millions of lives being lost due to direct or indirect causes of COVID. It has changed the picture and the way we see ourselves and how we see ourselves at the micro or very, very specifically at the macro level. So a little bit about COVID, somebody wants to read up. If somebody has a question, I'll be more than happy to go over the COVID symptoms, talk more about detail. But how the no entry without the mask, the social distancing, the whole COVID itself affected us psychologically. You know, it's huge. You know, I have friends I haven't seen in months, and I'm not the only one. We have relatives, we have families we cannot travel. It affects us in at so many levels. Current study is supposed to help us understand the effect of social isolation and reaction to pandemic causes negative psychosocial economical effect and somatization from the multicultural background. So pretty much I think breaking down the depression, the somatization, the social isolation, where we're coming from and some of our values, I think that ties all into the actual research we're talking about. We looked into this historical aspect of pandemic, the examining the medical preparedness to health crisis, and we already know we were not as well prepared, and even access to the care is still very limited, especially if you're dealing with someone in Michigan, more specifically Metro Detroit, and particularly in Detroit, Wayne metro area. Most of our people barely had access to health and mental health services. Where we are located, and my colleague is actually right here, she will attest to that. We are pretty much the only agency in miles radius who is providing or mental health services or even walk-up services for anybody in need. Is quite disturbing. But adding the COVID component to it, it just made things worse. However, again, going back to the research, we also were able to analyze the mental health crisis among, again, our chosen population. And then we learned there are huge disparities, mental health disparities in addition to health disparities, which actually negatively affected the well-being of our individuals and their productivity in the society. The impact of socioeconomical factor on survival was huge. It's like in terms of, we looked at it and we found huge discrepancies, if you want to say. It's like the numbers were at two different opposite ends. And then when you compare it to the mainstream population, they don't fall that far apart, yet they are still significantly lower compared to compared to Caucasian or African American population. They have the self-awareness and they do have somewhat access to the services, or they're rather mobile because of their family ties or economical status. But then Arab American population, even though they might be economically strong, they're not as well connected and well versed to be able to research and able to go get services, especially for mental health. The cross-sectional part of the study actually carried out, and we recruited about 500 individuals. At our agency, iAmerica Behavior and Mental Health, our offices, mainly our offices which contributed again was Detroit, Garden City, Hamtramck, and Kenton. And then we had a few people, they actually were receiving telemedicinal services to the teletherapy. The main assessments we utilized were DPSI, PHQ, and GAD in addition to SSI. However, down in this presentation, I do have a couple of other assessment suggestions any clinician would like to utilize at their practice or what they're doing. Hopefully that will help them. Talking a little bit about hypothesis, we talked about, like I said earlier, the pandemic has caused few hypotheses. We talk about increased emergence of variety of mental health issues. It did increase the issues, particularly depression in Southeast Asian and Arab American. We also looked into the pandemic has caused increase in health issues and somatization with depression, and women. We wanted to look particularly into children and women compared to the men. So it's one of the study, like I said, with cross-sectional, your hypothesis pretty much, are more like a bullet points here. So some of the aspect with the assessment, it evaluated biological, social, environmental, and psychological factor tying into the mental health diagnosis, which also talk about interpersonal trauma and grief, because if we go back and people who are familiar with the assessment used in this study, they will attest to that these all ties into the mental health and interpersonal relationship. And then evaluation, which in turn help us diagnose clinical diagnosis. The rise of mental health crisis, again, we already know we are in crisis, so mental health ties into the bigger picture of crisis. We're not talking about health, but the mental health aspect we're still trying to evaluate, but it looks like it has been pretty painful to learn. The footprint is quite huge. We were already talking about $1 trillion spending trying to take care of mental health issues and identify, but then seems like it has increased tenfold. One of the comparison, and I really like the picture here. So if it was one-fold, the medical footprint, the psychological footprint is like 10 times bigger at the moment. Some of the mental health illness, again, we particularly looking into depression and somatization, it is the significant risk factor for chronic non-communicable illnesses, which again include the physiological diagnosis. And then don't forget, we're not really concentrating on substance abuse or addictions at the moment, but again, this is something we do definitely want to look into further. Overall, worldwide, according to the studies, before COVID, we had 12% or more population affected by mental illness. Now I said tenfold. Let's talk about, I would say, just from the sample, if we will have 100 people coming in a week, I would say we will have probably 20, 30 people diagnosed with depressive or more like organic disorders, but now we're talking about at least 60 or more than 50%. And mostly, yes, it's women and children. It just has increased a lot. Some of the risk factors we learned prior to pre versus post. Pre-event with more social economical status, we already know, we always look into the work, the environment, underlying health condition, talk about health, we talk about how much health we have. But then the event, the disaster, the little, the huge change of our life event, after that, now we also talking about recovery. We are pushed to talk about recovery, yet there's no recovery. There are bonuses being offered to get the job, but then there are no jobs. We are in tenfold more stress than we were before. The vision, the perception has changed, and both as individual, family, and social level, because you're still walking on two-edged sword. Don't know what you're gonna bring home, and you don't know where you're gonna go with your economical situation, your financial ability to pay the bills and all. So inequality among rich and poor during COVID, again, it's huge. I just had to talk about that. There's a little line in between, and then you can see the inequality. You know, it has just increased many fold over, because believe it or not, we used to say poor become poorer and rich got richer, but after COVID we cannot say that anymore, because we're all going downward, whether it is health, mental health, or even financial ability, and it affects how your society is going to recover from the after the pandemic, because we really don't have anything we can count on. We can count on starting new businesses, and in turn it affects us a lot. And again, it is going to we are at the risk of starting in a larger scale pandemic, if not epidemic, which gonna be focused right on mental health. So having that said, well, I guess I'll go back and just check that. I want to emphasize on long-term effect on mental health of our pandemic, but in addition to how our health and mental ability to comprehend what we are going through has deterred over a short span of time. So again, talking about socioeconomic status, decreased ability to access to mental health and health, and again, it equals to increased risks of illness. Somatization stress, in case somebody's wondering, but in this day and age, after COVID, the increase, we have more people who are showing increased anxiety and uncertainty, feeling loneliness, sadness, impulse, anger, eating issues, sleeping issues, increase of substance abuse, burnout, exacerbation of existing mental health concerns, GI, cardiac, respiratory, and other health issues. Some of the suggested assessment for the future study, or anybody who is going to assess at their current placement. These are some of the assessment I strongly recommend and we're currently using. Talking about the result, we saw about 79% increase in the diagnosis and 85% more increase or higher diagnosis, higher scores post-COVID. We also saw a huge increase in young people getting diagnosed, in addition to moderate to severe, and it's very little about mild depression. Loneliness and isolation score has also quadrupled. And of course, we cannot just ignore the fact that 709% higher depression screen were deducted August 2021 in 2021 versus January 2020, which was like beginning of COVID. But again, we have to realize at the time everything came to complete stop. We did not have that many people, and then research didn't really begin until more towards the end of 2020. So of course we did not, I cannot say confidently that we were, if we were to go back in time, we will have more, what we call it, our numbers would be much higher. However, at the same time, we just did not have access to that many people in the beginning of pandemic, because again, everything came to complete stop. Now again, women somehow are more prone to be diagnosed than men, but then I can confidently say men are also being diagnosed a lot, but again, men are always resistant, especially people from ethnic groups, to get help. So this is something coming in, but then huge majority of people who are currently coming, especially male who comes in, they are referred through their jobs under FMLA or EPA or FMLA. They are not volunteering to come in unless they have existing mental health issues. So overall, I would say COVID, our current pandemic, if you want to take it a step down pandemic, because somehow we are recovering, it still has jeopardized a lot of our values and how it affected us, how we make money and work. Lives are more stressful. We have less resources, and we do need to analyze and conduct more studies. Scope of practice, again, our psychopharmacology or psychotherapy, these are the two primary methods of treatment for the illnesses. We do need to look more into teletherapy. I agree that this is something which helps a lot, helping diagnose and maintaining and stabilizing the symptoms. It did break down the geographical barriers. It did help. However, there is more consideration is needed, so we can actually utilize help to reach more people. Do you want to talk about future consideration? Full spectrum of pathophysiological effect are still unknown of depression and somatic factors. However, we do need to pay attention to access of care, in addition to looking at different individuals and population, have basically more studies gearing specifically towards our ethnic group and our ethnic population, or even isolating population based on, let's say, counties and our cities. I would say it's more relevant for iAmerica because most of our people live in Wayne County, and almost 90% plus of our population, they will fall below the poverty line. So in that sense, I would say it does make sense for organizations like us to sponsor more studies to ensure we understand our population and their needs. So more studies are needed geared specifically towards certain population and certain needs in order to advocate for their health and safety better. And at that point, I'm ready to take any questions.
Jazakallah khair, Dr. Latif. So the way we're doing this is we're going to save all questions for the end. So we're going to let Ms. Zainab Suara speak for 30 minutes, and then at 4:15 Yale time, we'll entertain questions for both speakers. And we request that any questions be that you write your questions in the Zoom chat box, and we'll get to them in 30 minutes. And if anyone in the live audience has questions, I have cards, so feel free to write this here and we can read them out during discussion time. So Dr. Latif, thank you so much for your illuminating presentation. And I request that you put your screen share so that we can let Ms. Zainab share her screen for the next presentation.
Thank you.
Thank you.
I appreciate you. How do I? There you go.
Okay, so I'm just going to make Ms. Zainab a co-host. Hold on. How do I make them co-host from this screen?
From what?
Assalamu alaikum, Ms. Suara. So we've allowed you to share your, we made you co-host, which means you can share your screen. So we'd appreciate if you could share your presentation for us, and we'll begin in a minute, inshallah.
Assalamu alaikum, everyone.
Yeah, it's a pleasure to have you. So just for the sake of the audience, I'm going to introduce you real quick with your bio. So Ms. Zainab Suara is a psychology intern at Vanderbilt University Counseling Center and a PsyD candidate at the University of Hartford. Additionally, she earned her BS in biology from Howard University, her MSPH from Meharry Medical College, and her MA in clinical practices in psychology from the University of Hartford. Zainab's interests include health psychology, specifically mental health disparities, working with individuals who have suffered trauma, as well as providing culturally competent mental health services. And we're really grateful that we have women like Dr. Latif and Dr. Zainab Suara working at the front lines to help people who need it the most. So without further ado, we hand the floor over to Ms. Suara. You have 30 minutes to speak, following which we'll have a Q&A session, inshallah, for both speakers.
Inshallah.
Thank you.
No problem. So today I'll be talking about my dissertation that was focused on incorporating religious content, utilizing CBT with Muslims who suffer with depressive symptoms. So kind of like a brief background is kind of like there has been a lot of growth of Muslims within the United States, but unfortunately due to this growth, as we all might know, like the data on psychiatric diagnosis on Muslims is pretty rare. And, the information that is available, there's a variety of diagnoses, including depression. And research has shown that discrimination in the forms of racism or Islamophobia and or xenophobia can help contribute to mental health concerns. And due to several barriers, little is known about Muslims that are able to access treatment and kind of like what their experience is like, and if religion is incorporated into the treatment at all. So there's about 3 million Muslims currently living in the US and a projected 8 million by 2050. Muslims represent one of the most culturally diverse religious groups within the United States, and different patterns of migration, nationality of origin, and experience of diaspora can then impact each and everyone's Muslim experience within this country. So kind of like, as I mentioned before, there has been research that talked about the negative effects of discrimination, Islamophobia, racism, and xenophobia. So I thought that it would be helpful to give a brief definition of what these terms are. So Islamophobia is defined as unfounded hostility towards Islam and a fear of dislike of either all or most Muslims. Since 9/11, a lot of favorable attitudes have been towards Muslims that have only increased, since some Americans would erroneously associate Islam with violence, fanaticism, radicalism, war, and terrorism. Racism is defined as a societal system in which individuals are divided along socially constructed dimensions, and power is unevenly distributed, either based on race. So it can take many different forms, levels, and expressions as settings, as well as perpetrators and targets. And finally, xenophobia is defined as attitudinal, affective, and behavioral prejudice towards immigrants and quote unquote others perceived as foreign. This is usually defined as the presence of in-groups versus out-groups. Some people might describe this as us versus them. So this effect that either Islamophobia or racism or xenophobia or even, the wonderful mixture of all three, it can make living life in America excruciating. And these negative experiences can even lead to distressing psychological issues and potentially worsen any existing mental health issues. So what does mental health in the Muslim community look like? While there has been an increase in articles and books and other scholarly works detailing issues that Muslim Americans face, it's still incredibly limited within the literature. And, the research that is available suggests that Muslim Americans are impacted by by mental health issues at a rate similar to other individuals within the Western world. And it can be implied that if the rates for Muslim Americans are similar to the general population, and on top of that, Muslim Americans are dealing with discrimination, the need for mental health services would then either be higher or the same as other cultural groups within the United States. So what are some barriers to seeking treatment? So it could be internal, it might look like stigma, or it can be external, so either the lack of culturally competent care. So stigma, there's often a strong stigma attached to seeking professional treatment of psychological issues. This could be due to, misattributing mental health disorders to a lack of faith or, difficulties with spirituality, maybe spiritual possession or evil eye. Additionally, the individual may be viewed as someone who's lost their faith in God or lost their way. Individuals might have been told that they need to toughen up, or they fear judgment from their communities. And also, it's been observed that mental health professionals have been exposed to very little content about Islamic beliefs during their training. And culturally competent care is defined as a set of congruent behaviors, attitudes, or policies that come together at a system, agency, or amongst professionals that enables them to work not only effectively, but in cross-cultural situations. And one can conclude that if a Muslim is able to overcome the internal and external barriers to treatment, they might not then be met with a mental health professional who understands, who respects Islamic values. So there might be a reliance on cultural or religious leaders. Imams and Muslim faith leaders have a deeply impactful role, and many Muslim Americans may be more willing to seek help from religious leaders rather than clinicians. In a study, up to 95% of imams reported that they spent more time conducting counseling activities and addressing concerns such as family problems, relationship issues, or mood and anxiety concerns. But unfortunately, imams are less likely to receive formal counseling training compared to clergy members of other faiths. So very briefly, I'm going to give an overview of Islam, the spiritual tenets of Islam, the religious practices within Islam, and variations in belief. So the spiritual tenets of Islam. Islam is an Abrahamic monotheistic religion with origins in the Middle East, with belief there is only one God, and Muhammad is the messenger of that God. Muslims believe in the oneness of God, his prophets and his messengers, holy books, angels, predestination, divine intervention, and the Day of Judgment. And then while there's variation in adherence to cultural practices or beliefs, there are 5 tenets or pillars of Islam, which include Shahada, Salat, Zakat, Ramadan, and Hajj. So even within the same sect, there could be different beliefs, either based on like cultural factors, where they are, where they live, what the community looks like. So that's why there's a large variation in Islamic belief. So there's Sunni Muslims, Shia Muslims, and Sufism. So it's kind of just like each one differs in the way that they approach Islam, how they might view Islam, which tenets are important to them, and kind of just like what are the cultural factors that might be impacting how they view Islam. So why would it be important to incorporate religious beliefs to address mental health concerns of Muslims? So it's kind of like, first we'd need to differentiate between spirituality and religion. So spirituality is understood to be the search for life's meaning. It emphasizes a search for the sacred, while religion often incorporates rituals or certain behaviors that would receive validation from a group. And often these two are difficult to tease apart because religious structures are shared by a group, while spirituality usually involves both a belief and a relationship with a higher power. Both spirituality and religion can provide individuals with the ability to understand their life experiences as well as make meaningful connections. And research has shown that both religion and spirituality are protective factors in insulating people against mental health concerns. So how are they protective factors? So it's kind of just like, you know, as I mentioned earlier, with racism, Islamophobia, and xenophobia, you know, with the Muslims face, how can we then use religion or the practices or beliefs within religion to help, you know, safeguard people? And, you know, if they're dealing with mental health concerns, how can we make sure they're able to manage it? But unfortunately, the studies that have shown that focus on religion and spirituality as protective factors tend to focus on a Western Judeo-Christian lens. So what might be some religious mechanisms that would protect Muslims? So social religious engagement, providing a sense of community. It could be by reading holy scriptures and increasing prayers to Allah subhanahu wa ta'ala. It could be praying and seeking support from community while dealing with stressors, religious rules against, you know, maladaptive coping skills such as smoking, drinking, or other high-risk behaviors. Some spiritual mechanisms, you know, belief systems that can be drawn upon to supply meaning during times of distress, being able to provide skills that help manage anger and resentment. You know, the belief that one has a relationship with the divine can, you know, provide a source of meaning and self-esteem. It might make it a bit easier to have a sense of patience in the face of adversity through gratitude or through prayer. So, you know, how would one tailor treatment then? So it could be through intake interviews. It could be due to, you know, diagnostic formulations. It would be important to inquire language preferences and how does the individual then define their own race, ethnicity, or culture. Immigration history would be important. You know, it would be important to be aware of like how Muslim clients identify within Islam and if they identify with different sects. And, you know, the important thing is that the questions about religious practices should be posed in a non-judgmental way. And also the therapeutic alliance can be really powerful and really important through the use of using culturally specific metaphors, proverbs, stories, and analogies that can help promote a sense of self-esteem and self-efficacy in a culturally appropriate way. So why CBT? So CBT is one of the most empirically supported evidence-based treatment modalities for helping those with depression. And, you know, while it's been heavily researched and, you know, empirically supported, it's been very much focused on the majority of white Western lens. And it can be effective and it can be easily modified to work with, diverse groups and populations, either through case conceptualization, the emphasis on the client's expertise, the emphasis of, it being a conscious presence where both can be self-described and taught to others, the focus on cultural strengths and supports, and a focus on environmental influences that could impact thoughts, emotions, or behaviors. So this is very brief kind of like studies that have focused on using CBT from a religious perspective. It was either with those who identified as religious and were diagnosed with OCD, those who were diagnosed with major depressive disorder and were dealing with grief, those who had been struggling with dysthymia or really persistent depressive disorders. And throughout, there was always that identification of both behavioral and cognitive techniques that, could either be, experiments that they might do, or modification of core beliefs, keeping thought records and recognizing patterns that were impacting their mood. It could be discussing religious issues. It could be, giving advice, based on the Hadith or Sunnah, being given the encouragement to pray. It could also be, using a religious viewpoint on how to explain how depression might come up, talking about giving behavioral recommendations using Islamic sources, reading the Quran, encouraging to perform dhikr, like identifying negative thoughts and, lifestyle changes that might be really effective. And I do apologize that I'm speeding through. So it's kind of just like, but what are the experience of mental health providers delivering services to Muslims? Not much is known about what providers do in therapy. As previously stated, therapists should have a knowledge about the discriminatory societal issues that impact Muslims, but as well as religious and spiritual issues as well. So my dissertation aimed to answer what aspects of CBT have been modified for Muslims with depression, what aspects of multi and religious competency are important for them to know. Does the level of client adherence to Islamic religious or spiritual tenets impact how the therapist then modified CBT? And is there a difference between Muslim and non-Muslim therapists and how they modify CBT? So the methods. So essentially, I sent out an email advertisement with a link. When parties clicked on the link, they'd be asked to give informed consent. Once the informed consent was done, they were able to ask some questions about whether or not they'd be an appropriate fit. Then they would be given, if they met the selection criteria, they'd then be given a survey that talked about demographic information. And if they completed the demographic information, they would then be led to an addendum about audio and video consent. And if they agreed to an interview, I then reached out to them, either through the telephone or through Zoom, to have an interview. So I sent out a recruitment statement through personal emails. I posted on Facebook groups. I recruited through the Connecticut Professional Association, as well as many different professional organizations that were focused on Muslim mental health. I also searched on Psychology Today that noted, or for any therapist that noted experience with Muslims or CBT or both. And then I used a snowball technique if I did get a response to kind of figure out, would they know anyone that could also be interested? The demographic survey focused on educational background, training, gender, race and ethnicity, experience with Muslim clients, while the interview focused on professional status, their opinions on competency, how they incorporated religious materials, their knowledge on specific CBT techniques, their knowledge of basic Islamic tenets, and kind of a debrief. So the selection criteria that I use for my study is that each therapist must be independently licensed. They must use standard CBT techniques routinely in their practice. They had to have seen at least 2 adult Muslim clients for at least 5 sessions where the treatment of depression was the primary goal, and they were willing to be contacted. So then the minimum number that I aimed to seek out was 20 independent license. So I sent out a total of 596 emails. So I got a number back, but there were only about 35 people who completed the interview and ultimately 6 people who participated in the interview. So what were the characteristics of the survey participants? So the 35 total participants were those who completed. Majority were licensed professional counselors or mental health counselors, then followed by marriage and family therapists. There were some licensed clinical social workers, There were licensed psychologists, some were mental health, medical practitioners, either through psychiatrists or nurses, and then 7 identified themselves as not licensed or did not provide licensure status. In terms of experience, 14 indicated 1 to 5 years of practice, 7 indicated 5 to 10 years, and 11 indicated at least 10 years. 22 participants noted experience with CBT, and 29 participants indicated training either through coursework, clinical work, workshops, or trainings. As for the most utilized CBT techniques, it was cognitive restructuring, identification of core beliefs, and identification of underlying assumptions and action plans. Other treatment modalities participants noted was an integrative eclectic approach, client-centered narrative or relational, acceptance and commitment therapy, psychodynamic, and trauma-informed. A majority of the participants were between the ages of 30 and 39. 31 participants identified as female, 40% identified as Asian, about 35% identified as Middle Eastern or North African, 80% identified as Muslim, and there were a variety of treatment settings, community mental health, hospitals, substance use, and school settings. What about the interview participants? What did they look like? As I mentioned before, 6 participants completed both the interview and the survey, and the interviews ranged from 40 minutes to 1 hour and conducted via Zoom or telephone. 3 were licensed professional counselors. 1 was a licensed marriage and family therapist. 1 was a clinical psychologist. 1 was a psychiatrist. 1 identified as white, 2 identified as Asian American, 3 identified as Middle Eastern. As for gender, only 1 participant identified as male, and all interview participants identified as Muslim. So how is then the data analyzed and kind of like broken down? So the data that was collected through the surveys were examined for descriptive frequencies and percentages, but as for the interview data, I looked at it quantitatively through grounded theory by identifying common emergent themes, multiple narratives, and if there was any differences in overall themes. I used a freeware software called QCA Maps. Once all the recorded interviews had been finished, I entered the transcripts and conducted clusters, and then compared the clusters versus ones that I had identified myself so that the process was free of bias. And there was a high level of agreement between what I had identified and what the software had found. So what were these common themes? So all of the therapists mentioned that there were common presenting problems such as relationship dynamics, either between their client and their family, religious exploration, identity development, difficulties with acculturation, as well as formal diagnosis of depression, anxiety, experiences with trauma, and difficulties adjusting due to the pandemic. Each interviewee noted that rapport building was really important. Discussion of confidentiality was really important because clients were often fearful of whether or not people would find out they were in therapy, whether things that were discussed in therapy would be brought to the larger community, and the stigma of being in therapy. And client religiosity was typically asked either through the intake interview or through questionnaires submitted to the client. Overall treatment approaches, while each their interviewee noted that they use CBT, there were a lot of eclectic approaches, the use of acceptance and commitment therapy, and the use of trauma-informed. And how CBT tended to be modified was the separation of behavioral and cognitive approaches. So there might be, behavioral approaches that utilize salat or dhikr, reading the Quran, or cognitive approaches that would use, common Islamic beliefs, like one must fully rely on Allah subhanahu wa ta'ala, tests are viewing difficulties as a test from Allah subhanahu wa ta'ala. And there were treatment recommendations that were often separated into what they believed Muslim therapists should do and what non-Muslim therapists should do. And pretty much commonly it was, don't make assumptions, be non-judgmental, take the approach of a student, don't be afraid to incorporate Islamic beliefs, and as well be aware of cultural religious factors that could impact clients coming into the room. Commonly utilized practices were salat, fasting, dhikr, charity, hadith, sunnah, and tawbah, the process of repentance. And then commonly utilized beliefs were one must really trust and rely on Allah, life is only temporary, focusing on the hereafter, afterlife, perceiving difficulties as a test from Allah, remembering sins are forgiven, with hardship-based ease, focusing on a loss of Panala's blessings, and remembering that a loss of Panala is compassionate and merciful. There were a couple of caveats. A lot of the participants said that life is only temporary and focusing on the hereafter, the afterlife, they wouldn't use with those who were severely depressed and who were struggling with suicidal ideation, because that might make them more inclined if, you know, they were just focused on the temporariness of this world. And then also someone noted that maybe perceiving difficulties as a test from lost Panala. Some clients might find it invalidating of their experiences and not receiving a lot of support from their therapist. So what were kind of some limitations of my study? There was a low sample size. Unfortunately, I was only able to get 6 participants. I could recognize that with the pandemic and most interviews being virtual, and a lot of therapists being called on in so many different spaces, there's probably a high level of burnout. There's also selection bias because people who would respond to the survey, fill it out, and be interviewed already would have a lot of specialized knowledge of CBT and working with Muslims. And there was also researcher bias, since I was the one who was conducting the interviews and, you know, the one selecting the participants. And the advantages is that because it was a qualitative study, it was incredibly detailed and a lot of descriptions, and it opens up possibilities for future research. So what are some implications for working with Muslim clients? Throughout, it was most importantly that individuals remain knowledgeable about Muslims, know about common Islamic beliefs, common practices. Rapport building is incredibly important. This could either be by utilizing a non-judgmental approach, by discussing confidentiality, by letting clients know that they wouldn't be judged in a space. Like a non-judgmental approach was very highlighted through each interview that I had. And kind of like implications for future research, I would love to see this study be conducted with larger sample size so that it could be more generalizable. While one of my research questions was to look at non-Muslim therapists, unfortunately, I wasn't able to get any participants. So it'd be cool to see if non-Muslim therapists are able to modify CBT by incorporating either religious beliefs or practices. And also the study was focused on the therapist's view and experience in therapy. So it'd be really important to see, like, what are the viewpoints of their clients? Like, what do they feel was important? What do they wish they could have seen in treatment? And I wish this study had explored a little bit more about the relationship between culture and religion. Like, and if there's any differences in, you know, someone from a certain part of the country, a certain, you know, country in the world, I really wish we would have gotten more information about that. And then if there's any differences between those who have reverted or converted to Islam and how they then engage in treatment. And those are all my questions, if there's any questions. And I just want to say thank you all for listening. I know that it was very quick.
Okay, thank you guys for your wonderful discussions. So we have Professor Blumi here today who will be our discussant. So she's gonna kind of lead the discussion on what we just listened to and ask some questions to our presenters. If you have any questions in the Zoom chat, please go ahead and drop them in there. And then if any of you guys have questions, I can hand out some slips of paper for you to write them on. Show of hands if anybody has a question you want to ask. Okay, perfect. Oh, I'm sorry. All right, I'll give you yours. Thank you.
All right. Assalamu alaikum. It's wonderful to have our presenters. Thank you for sharing your knowledge, both on looking at depression among Arab Americans in the context of COVID-19 and then CBT with Muslims. And so I appreciate the knowledge you shared. I do want to let people also know, I know it's been mentioned, if you are joining us virtually, that you can also put your questions in the chat. I can see it come up, so I do see the Zoom screen, so I don't know if the questions, if you're joining us through the app, will show up. Do you know if they will? Sorry. You know, if the ones that people are joining through the app, will it pop up in Zoom? That's a good question. So if you could join through the app to see, yeah, we'll check that. But I know there's one question from the audience here. So we'll start with that, and then I'll ask some questions if there aren't any. Did you have a question, sister?
Right now, should I just say it?
Yeah, you can just say it and I'll repeat.
This goes for Dr. Latif, the first presenter. You know, she's a psychiatrist, and I was wondering if she utilizes any special techniques or strategies in treating depression in Muslim patients.
Are there, so this was for Dr. Latif, and please correct me if I'm wrong in stating the question. Did you utilize any special treatments or techniques when working with Muslim clients? Dr. Latif, are you still there? If you are muted. I can see your screen. You are muted.
Forgive me, I'm trying to unmute. Sorry.
No problem.
Question for me. Thank you.
Did you hear the question? Would you like me to repeat?
Okay, I'm here. Sorry, I'm
Okay.
just. Forgive me. What is the question?
Yes, and please correct me if I restate it incorrectly. The question was, did you use or do you use any special tools or techniques specifically when working with Muslim clients?
So the number one thing, but thank you so much for the question. Number one thing when we are working with Muslim clients is face-to-face contact. It's very important for our population we're working with. Somebody comes in, because don't forget, yes, we're talking about Muslim, but then, or even though we say we have very mainstream person coming in, but again, as a Muslim, we have dealt with discrimination, lack of access to quality of care, and distrust among authorities and authoritative figures. So a lot of people, especially our immigrant families or first or second generation immigrants who cannot easily blend in, they prefer to come in for face-to-face evaluation. They want to see who we are. They want to see where we are. They want to see who their provider is. And then again, it almost sounds like their one foot is out the door the whole time, because they're looking for a reason, and there has to be a very solid, heavy reason or obligation for somebody to tell at least Southeast Asians they have to be in therapy. So that's another thing, because they're undecisive. So people come in, they have to be there. They need to know who you are. They need to know how your organization works before they come in. When we comes in for the evaluation, we'd like to call it person-centered, family-oriented, evidence-based research questionnaire type approach, where we are actually asking a lot of direct questions, but then instead of asking very direct personal question, we have to go into the health assessment, the environmental assessment, the health specific issues, medication, before we come back and say, okay, so what brought you here? So that's another thing. So you have to have a very integrative approach, and we cannot just sit down and say, hey, what is your sexual orientation? Nobody gonna like that. So that is the attitude, I would say, before we look into the assessment. Now, in terms of assessment, we can always utilize mainstream assessment. For example, we can do the PHQ GAD. This is very commonly used, and mini mental status exam. But however, even the Zingerman and Zingerman mini mental status exam, you can just hand a paper and say, hey, can you draw a circle and a clock and fold the paper and then stand on it? It's not going to really buzz. So there are certain things which are culturally inappropriate and rather considered insultive for our population. So you have to really modify some of your evaluations. I really hope we have standardized assessment out there, which we say, okay, this is what we're going to use for Southeast Asian clients because this is culturally appropriate, or Middle Eastern client, or somebody who is not going to be aligned to, let's say, one commonly misconception is MMPI. I never met a single Muslim immigrant, first or second generation, who actually was able to take the MMPI and still score within the norms. I haven't done that, and I've been doing this for almost a decade now. I've been hand scoring MMPI since 2012, and like I said, I have probably scored at least 1,000, if not less. But again, it all goes back to the values and cultural values and your beliefs. So, short answer,
Sorry.
they do standardize assessment.
No, before you, I know you're about to continue. I just wanted to ask, could you clarify what the MMPI is?
Oh, let me put that down. My friend, that's Minnesota Multi-Facet Personality Inventory. It's the gold standard if you ever want to test somebody clinically. Here, I just put that down here. If you ever want to test anybody's personality assessment, or you are going to assess anybody whether they are fit for a certain job, you would do MMPI. For example, anybody who has been prescribed controls or had any concern with their behavior, they are administered MMPI. Anybody who is working or getting promoted to be a bishop, it's required for them to take by different churches. In addition to that, I believe it's also administered for anybody who's working or going to be hired into Rank 19 or higher with the federal or state government. So it's something, it's right there. And a lot of surgical clearance requires MMPI as well.
And I'm sorry to have interrupted you. I just realized that I wasn't quite clear
Like
on
I
it.
said, I would love to
others.
have had, I wish I knew a more straightforward answer to the question. It was a loaded question. There is no standardized assessment. So anything we are using, we have to proceed with caution.
Thank you. And I'm looking at the chat also.
Oh, sorry. Now I'm seeing the question here. Now I click on the right window. Assalamu alaikum, Sister Noreen. Thank you. So these are the questions in the chart, in the chat.
I think it's submitted to the Huva app chat. So with those in Zoom, you can't see it, but I think in Huva or Wova, I always mispronounce it.
Okay.
Oh, they sent it to you
there?
directly. Okay. I think you sent it directly. What'd you say? Yeah, we can't see it, but thank you to those in the chat who have, I see Tisha Dean indicated that it's the Minnesota Multi-Phase Personality Inventory. So if you're interested in finding out more, I think we can all search for it ourselves. I also think it's interesting just to bring out what's being said in the chat, that someone said they failed it when they tried to apply to a Borders bookstore. So clearly there's some things based on what you were saying, Dr. Latif, about the application and what that means for American Muslims. Are there other questions before I ask some? And again, you can put them in the chat or as a group. This one is for Dr. Tabi Zainab. I was curious to know, hi. Oh, they said they can't hear anymore, or?
Oh, I didn't say anything yet.
Okay, no, Dr. Rabia Latif said she couldn't hear us, but it sounds like you all can still hear me from Zoom. So I'm curious to know, given that when your study was done, did anything come up in terms of challenges with COVID-19? Was that mentioned at all? And how did that emerge, and what was said about that?
Yeah, there were a few participants that mentioned COVID. One of the interviewees, she was working in a school setting, so it was just very difficult on how students were adjusting between like managing school and no longer having that structure and attending school online. And then they return back to school. What did it look like? You're not able to connect with your peers in the same way because you have to remain socially distanced and like masked. And then also just like a lot of the social supports that people typically would have, like being able to go to the mosque, being able to go to Jummah, being able to be in a group was taking it away from them. So it made it very difficult to connect.
Okay, thank you. And then this is a question for both presenters. I'm curious to know, and I believe you all touched on this a little bit, either in the background of the literature or in your findings, but if you could emphasize for us some of the facilitators and barriers to service seeking in general that you either came through your work or your own personal experiences with working with the Muslim population, any barriers or, and what were barriers to seeking services, as well as anything that you saw facilitated or made it easier for folks to actually seek services, whether it be in the context of COVID-19 or in the context of, and speaking to people directly or surveying people directly who would be seeking those services, or in the case of our second presenter, where you're talking to service providers, talking about their experience. From either one of you, you all, whoever would like to address that first.
I can go first. Kind of just like what was found in literature was kind of this idea of stigma and kind of just like who would know about me attending therapy, a lot of fear about what is kept confidential in sessions, a lot of fear about, would that mean that I'm a bad Muslim by like attending therapy and I'm struggling in this kind of way. And then just the idea of like, if I go to a Muslim therapist, will they judge me? If I go to a non-Muslim therapist, were they able to understand, you know, religious and cultural factors? And then kind of, as always, like with the general population, availability and cost. And, you know, one thing that I've also noticed specifically with the pandemic, it was this idea of, I don't have a space in which I'm able to speak freely, especially if, you know, my issues are focused with dynamics with my parents or dynamics with my siblings or issues within my community. A lot of Muslims tend to be from collectivist societies, and there's also this cultural factor of like, you don't move out of the house until you're married or going to school. So it's kind of just like that idea of like, what sense of privacy do I have in this space?
All right, we also have a question in the chat for Dr. Suara. The question is, what is your take on the concept of hiding your sins or religion-associated guilt? I felt like this might be one of the thought processes holding people back from therapy. And are there any resources you would recommend addressing this? This is from our virtual, one of our virtual attendees.
Hi, yes. I think it's kind of like, it was something that was discussed, kind of like this guilt and shame about why would I attend therapy? I know that for some of my participants, they mentioned the use of like bibliotherapy. I'm trying to remember the book. Reclaim Your Heart was a really popular one that they felt was a way of like, you know, connecting within relationships, trying to find values within relationships, trying to able to define like what's important to you and how can we like reconnect. I think oftentimes people feel as if like, because the sins that they've committed, because what they've done is, you know, outside the scope of what a quote unquote good Muslim should be, they then tend to isolate. They then tend to disconnect. They tend to feel less spiritual or religious because they feel as if they don't deserve to. So it's kind of like this idea of like, what are ways that we can either get you back to Islam? Would that mean like, you know, more time spent in sujood? Would that be fasting? Would that be charity? Would that be volunteer work? So kind of like those kind of ideas.
So a follow-up to that, were there any, and I think this is what you were saying at the end of your explanation, but were there any strategies that participants in your studies talk about in sort of pulling people from this idea of religious guilt by the time they got to services, right? What did they offer any ways in which they dealt with that with their clients who they saw were presenting with that?
Yeah, a lot of it was tied around like salat, of kind of just like, since that was really common for their participants to be struggling with, like if I'm struggling with my deen, then I'm not making my salat on time, I'm missing salat. So there was a lot of techniques that focused on like, are we being intentional and mindful when we're making wudu? Are we being intentional and mindful when we're in, you know, sujood? Are we being intentional and mindful with the surahs that we read? And it would be like, you know, are we waking on time for like Fajr? Like, you know, it can kind of be difficult when it's like dark and feels like the middle of the night, especially, you know, during the winter time. But it was like, how can we then kind of rethink of it and reframe it as like your one-on-one time with, you know, your Lord and being able to talk to them. So it would be like, I think there was a lot of mention of like the wellness shift and how everybody's like, I'm into manifestation and, you know, thinking about these kind of things. So it's like, how are we incorporating wellness? When you're waking up for Fajr, are we taking the time or are we rushing through? So those kind of things.
So sort of taking these acts of these religious practices and changing in or reframing them as mindfulness practices, right? As sort of helping. Hold on. Yes, this is Dr. Bumi, but I see Nasreen, you asked, can you unmute and add a comment to this? If you can type it in the chat, that would be preferable. We're trying to limit just the amount of free, just talking over that could potentially happen. But if you can type that, please do. And then we can come back to that in our conversation if it takes you a little bit of time. Is that okay? You can give me a yes or a no in the chat. Thank you so much. And then I just have a question for both presenters, and I don't know if we've lost Rabia, but if you're there, I hope you hear this. Both of you talked about some barriers in some way, whether they be economic. I believe, Rabia, you talked about FMLA, being connected through FMLA or being connected through services. So I'm curious to know, what were some of those barriers that, well, I already asked about better barriers. Actually, I'm curious to know, what recommendations do you have for eliminating barriers to services that are around more structural concerns? Maybe, one are social circles, but also those economic concerns around even seeking services in the first place. Those very specific type of barriers, or those who might not have work and that's the way they're being, you know, not able to be connected to services that way. I hope that question is clear. I think I've layered on a lot of things, but you both talked about this economic aspect, and I'm curious to know what recommendations you have around that for Muslim populations. I think we might have lost Rabia for a bit. So Zainab, it's all you.
Okay, no pressure. I think as you were answering the question, unfortunately, like within the United States, insurance is tied to employment. And oftentimes a lot of therapists, while, you know, they'll take insurance, it might not be on a sliding scale. It could still be really expensive. I guess one thing that I would definitely recommend is, you know, support groups. They tend to be either free or low in cost. I definitely recommend books that are focused on like mental health with an Islamic perspective. I know that it can be kind of hard trying to find therapists that are Muslims and, you know, that would discuss mental health concerns in a way that feels like non-judgmental and open. But I, you know, through my study, through the various emails that I was sending, and there were a lot of professionals that were really focused on like skills and how they could best provide help in the best way possible. I'm so sorry, I don't think that's making sense.
It's okay. It makes sense.
Okay, books and support groups. And I would look through Psychology Today. There is a section that's focused on like Muslims and Islam, and you can click through and go through those providers and see if they do have a sliding scale, if they offer any support groups, if they offer a way that they could work on with the price.
I think what's so interesting in both of your conversations is what came up to me and has come for me over the work I've done is this very important need for community education, not just on, you know, mental health and what it is, but how to access it, right? So you started listing psychology, like people don't know, you know, that's not something anybody would just know. So there is this piece of reducing that stigma that you talked about that may be a barrier to seeking services in the first place, but also the ability to even understand how you navigate that system, right? How do you even get to the place of seeking services? And I wanted to ask Rabia in the ways in which she engages in community education? Because to get the sample size you did, I imagine that there's some deep connections you have in community, but I don't think she's on the line anymore. I think there might be some technical difficulties. So I'll just put that out there, and hopefully if she's hearing this can jump in whenever that is the case. I do have another question for you that came up as you were speaking. The people that you interviewed, did they have a diversity in clients? Like, did they see Muslims as well as those who did not identify as Muslims? And if that's the case, did they speak to any differences in sort of the ways in which they engage in practice or the things that came up for them in working with their clients?
Yeah, every therapist noted a diversity in age range, in race, in ethnicity, in religious identity, in sexual orientation, gender expression. And I think it was split of, I want to say 3 ways. Some participants were like, I discuss religion with every client. I asked them in the intake, I asked them kind of just like how they look at religion, whether or not they're Muslim or not, if religion is important to them. And then also the second group was like, I wait for the client to discuss it. If, you know, one interviewee was like, you could kind of tell, are they saying, you know, Allah subhanahu wa ta'ala? Are they saying inshallah? Either are they saying alhamdulillah in the way that they talk? That can usually give me an inference of like, if they're using it in everyday conversation, they must identify as fairly religious. And then the last group was like, I don't ask. And if my clients don't bring it up, I don't discuss it at all. So it seemed like there was 3 different ways that people could approach it.
All right. And we've got questions in the chat. I'll start with Masume, and then Nasreen has typed up her question as well. The question was, I'm curious, with Dr. Rania Awad's research that Muslim Americans are twice as likely to attempt suicide as other religious groups, if any particular religious or spiritual phenomenon were observed or addressed in relation to clients' suicidality in either presenter's work. Unfortunately, Dr. Rabia cannot hear us, and so we're gonna, that part, if you want, go ahead.
Can you tell her to try to exit and come back in?
Yeah, I just did. I typed it to her to exit and come back in. But we'll leave that to Zainab to see if she can address that, if that came up in your work. Yeah.
One thing that I noticed was that they might not push on certain religious beliefs because that might then further empower someone to attempt or complete suicide. The idea that life is temporary, that one should focus on the hereafter, afterlife. Participants seemed really reluctant to discuss that. And also they really wanted to make sure that if someone was, you know, experiencing religious guilt, and it was causing depressive symptoms, it was causing suicidal ideation, that it was really important to take like a non-judgmental approach. Every participant was like, I'm not a religious scholar. It is not my job, nor is it within Islam for me to judge you on the things that you've done or the sins that you've committed. But I want you to know that as long as you're in this space, whatever comes to mind, whatever you discuss is kept confidential, and I'm not judging you. I'm just going to try to help you figure out, how can we help your mood? What are some things that we could do? What are some things that can help you feel reconnected to faith? And if a client was like, no, I don't want to, I'm not interested in incorporating Islam, being able to back off was really important as well.
Okay. Thank you. And Nasreen has also typed out the question that she wanted to ask earlier, in the chat. I'll read it. I am a licensed psychologist. I work with Muslim and non-Muslim clients. Religious guilt holding someone back from seeking services presents a pattern of thoughts and beliefs they are buying into, likely following those thoughts of religious guilt and shame also creates a struggle within other areas of their life. One way I work with this is going with that train of thought and teaching clients to expand, explore, and understand the full narrative of that thought. If the data says you have guilt from sins, for example, by that same train of thought, you also have Allah's forgiveness. Oh wow, subhanAllah. Purpose to your struggles and the heart that feels guilt as evidence of your relationship with Allah, the Deen. That's really powerful, because I see you're walking them through that and using that very same position to then reframe the thinking, connecting that guilt to forgiveness. That's really powerful. So we must acknowledge the full thought. And when we do so, we begin cognitively to reshape the relationship with our thoughts and our relationship with Allah and other areas of our life. Thank you, Nasreen. That's really poetic and really beautiful. Thank you for typing that out. I'm sure that was a lot to type out to share that, but you stated it so well. I'm curious, Zainab, do you have any reflections on what Nasreen stated? I know she was building off something you said, so I'm curious if you don't mind also building on that as well, or any thoughts you might have.
Yes, I believe that is so beautiful, mashallah, and that's definitely something I'm going to take and use. I think oftentimes, you know, based on like cultural or religious upbringing, there's this idea that Allah subhanahu wa ta'ala only punishes, that we should only focus on like, you know, judgment rather than compassion or mercy. And I think having this viewpoint and being able to think of like your purpose and, you know, the fact that, you know, every time we pray, we say that Allah is most merciful and most compassionate. I think that that's a really great way of reframing and giving them a different viewpoint on it.
Are there any other questions, either from the chat, from those who are joining us virtually, or from our audience in person? I don't have any more, but I'm curious to know if there's anything that's come up for you that you want addressed. Anything that's come up for you that we'd like addressed. I'm going to wait a few seconds to see if Dr. Rabia rejoins, just because we still have time. So I'll pause. Is that okay if we just pause for a little bit to see if she comes back? And then we'll give it maybe 2 minutes. Is that okay? I'm asking our moderator if that's okay, because I also don't want to keep people. Is that okay? All right, so give it 2 minutes. I'll mute ourselves over here. So we do actually have a question here, so we're gonna keep going, and then hopefully after that question, we'll see Rabia again. But go ahead, what is your question?
So my question is, she had some non-Muslim therapists in her sample. Just wondering how were they able to figure some Islamic approaches or content CBT, whether it was just being sensitive, not being making assumptions, was there anything else like the religious content that they were able to incorporate, being not being Muslim themselves? Some of the challenges around training non-Muslims to it was Islamic integrated or integrated.
Yeah. It sounded like you heard some of that. I'm gonna paraphrase. Did you hear that clearly?
The question was, how did non-Muslim therapy best incorporate religion into therapy?
Yes, and I think there was a piece about like, how do you even go about training, or that was like training non-Muslims to even be able to do such a thing.
Yeah, I think it's a great question. Unfortunately, I didn't get any non-Muslim therapists within my study, so I'm not able to speak on that experience. But I think the most important thing is kind of just like not making assumptions, not leaning into biases, being, not only are you doing your own research, so you're not leaning on your client to share everything about Islam, be your sheikh, but by also being open and realizing that like not every Muslim is the same, not the way that they view Islam is the same, not, you know, the way the things that are important to them within Islam would be the same. So just making sure that you're being open-minded, non-judgmental, and knowledgeable.
Yeah, thank you. And I really appreciate the question, especially the part about training, right? Because I think I think it was in your presentation, Zainab, where you talked about, or you touched on the fact that there may be some Muslims who don't want to seek a Muslim for treatment. Was that you? Or I don't know if I made that. I think I heard that.
Yeah.
What did you say?
I did say that.
Okay, you did say that. And I think that that's an important piece about, we're here at this conference educating ourselves on the work that we do with Muslims. And I think that's really important. One, to recognize that we are not in isolation in the work we do, whether it be as researchers or practitioners or, community members. We're not alone in that work in trying to make sure that we are all well. But then what do we do for those who may not either, one, have access to Muslim providers or a Muslim community, and may have to seek services from those who do not identify as Muslim? How do we make sure that, one, we are the ones who are being sought out for the knowledge, right? To then train those who might be working with Muslim clients to ensure that they're not being educated in a way that's biased or has these ideals that sees us as less than, that doesn't speak to the like Islamophobia, xenophobia that you talked about in your slides, right? So what is our responsibility as practitioners, as scholars, as researchers to disseminate our work both within but also outside the community for also education purposes? I think that's something we can all sit and grapple with, given that we know not everybody has access. And then here's a question from Fatima in the chat. Assalamu alaikum. What advice and information would you give to a Muslim who is struggling with having so many incomplete projects and who is missing out on their Islamic duties as a result? For instance, for those who are feeling so overwhelmed as to where to start with so many unfinished demanding tasks on their plate, and just the feeling of being overwhelmed itself, what would you recommend to do first to treat the situation? And how can one become unstuck from such a slump?
Yeah, no, I think that is a great question and something that we all kind of grapple with. I mean, we live in a society, in a world in which productivity and output is tied to our worth and our value, and we can internalize that when we no longer feel productive or effective. So it would be really important to first, I'm just thinking first would be identify like, where is this feeling coming from? This feeling of overwhelmed, kind of just like how long have they been feeling this way? And maybe even inquiring like this feeling of overwhelmed, how has that been effective for you? Like, what is it getting in the way of? And then also just extending that self-compassion, that self-mercy of like, we are human, we make mistakes, we stumble, but it might not necessarily be a fall. And, being able to talk to ourselves in a way that is compassionate, because oftentimes what I've noticed with people who consider themselves no longer productive, there's this idea of like, you're wrong, you're dumb, you're stupid, you should be doing this, you should be doing that. So kind of just like, how can we talk to ourselves more kindly before we even engage in the work? Because it then becomes like a self-fulfilling prophecy if you're thinking, I can't do this, I'm overwhelmed, and then you're not able to do it. And then also just by breaking things down into smaller parts, sorting things out. Is this urgent? Is this important? Do I have to do this right now? What are the small steps that I could take to complete this thing? Like, oftentimes Salat is the thing that people struggle with most. So it's kind of just like, can I hit Fajr, then Duhur, then Asr? Like just breaking it into smaller parts and doing it one thing at a time rather than all of the things that I'm missing would be my recommendation.
Thank you. We're going to take that as our last question. If we could give a final round of applause to our presenters. Thank you all, for those of you joining us virtually and those of you joining us in person, for asking questions, being present. We appreciate you. This is not the last talk of the day. There is one more talk after this in the main auditorium just across the street, and then we will wrap up with closing remarks at 5. Thank you to our presenters. Jazakallah khair. Assalamu alaikum.